Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today is the second in a two-part series about the health of immigrants at the U.S. Mexico border. Dr. Alexander Tenorio is a neurological resident at the University of California, San Diego, and a first-generation American born to Mexican immigrants. He studies the serious neurological injuries that occur when people try to climb over the border wall and fall to the other side. Let's listen.
Dr. Alexander Tenorio, thank you so much for joining me on Public Health on Call to talk about neurological injuries at the U.S. southern border. But before we get right to that topic, it would help if you introduced yourself to our audience.
Hi, Josh. Thank you for having me. I really appreciate it. Currently, I'm a fourth-year neurological surgery resident at UC San Diego Health. A lot of my work, as you mentioned, has been studying the increase in neurological traumatic injuries at the U.S. Mexico border. And a lot of that, my passion and interest for this topic stems from my childhood. I am a first-generation Mexican American. Both my parents migrated from Mexico, really close to the same area where a lot of our patients are coming into, that San Isidro, Tijuana border here in Mexico. I grew up in a largely impoverished immigrant community in South Los Angeles, but a lot of my childhood was spent selling clothing on the streets of downtown Los Angeles. So I was the first one in my family to go through, college and medical school and neurological surgery residence. And given my background, given a lot of the struggles that we went through, and a lot of the struggles that I saw, my community go through, that's what really inspired me to advocate for the health of the immigrant population, particularly within neurosurgery, which I feel there's a great need for currently.
Well, that is an extraordinary story. What interested you in medicine when you were growing up?
I did see significant health challenges growing up. I was, especially for the immigrant population and Spanish-speaking population, I often served, I was, Spanish is my native language. I learned English in elementary school, and I was often relied upon to serve as an interpreter during clinical visits. We did, a lot of my family members did face significant barriers with getting appropriate healthcare or even signing up for health insurance. We weren't aware of the benefits we were entitled to, especially for poor immigrant populations or even just poorer populations. And that's what kind of I felt, given, the circumstances around where I grew up in, I always felt this great need for public service, right? For helping others in less fortunate circumstances, and seeing all the health barriers that we endured. That's what I kind of made me pivot towards pursuing this health career.
Well, and then you decided to pick one of the most difficult subspecialties in medicine, neurosurgery. I certainly remember from medical school the intense competition for neurosurgery spots for people who wanted to do that. Why neurosurgery?
Yeah, so I would say that neurosurgery is the longest residency and one of the more difficult ones. I mean, obviously the path towards becoming a physician is long for everyone and very, very difficult and challenging, but it is very rewarding. I would say that there's three primary components that made me choose neurosurgery. One of them, you just have to have a love for neurosurgical pathology and injury. That's just baseline, right? We all do. It's a very long, hard road. But secondly, as I mentioned, I did see that diversity within neurosurgery is, I'd say, behind. Just to give you a sense, there are less than 300 Hispanic neurosurgeons in the entire country.
Wow.
And as many of us know, that a diverse healthcare workforce is critical for health outcomes, right? Studies after studies show that the health outcomes of often marginalized communities do better when there's a more diverse workforce. And I saw that there was a significant need for a more diverse neurosurgical workforce, right? That was the second component. And the third component ties to the second component of the significant needs to start addressing these neurosurgical care disparities that I often saw.
Got it. Well, you are now in year 4. How many years is the neurosurgery residency?
It's 7. Yeah. So I'm almost done with my 4th one. So I like to think of it as I'm more than halfway through.
Wow. 7 years after medical school. Now,
yeah.
let me ask you this. As you get deeper and deeper into neurosurgery, it would seem that you would get further and further away from kind of where you started. Many people find that medicine and the world of medicine takes them into science, into research, into a lot of technical specifics, and away from communities and issues that affect groups like the one you're part of, and you partly went to medical school to help. How have you found that?
Yeah, as you mentioned, going as you go along into residency and try to develop your technical skills, especially in neurosurgery, which are very critical as we're often dealing with emergent life-saving conditions, and errors often could result in significant morbidity and mortality. We do have to spend a significant amount of time perfecting those technical skills. The way I've been able to stay within within my community and involving with advocating for the health of immigrants. When we first started noticing the trend of more brain and spinal injuries coming into our trauma center, that's when we started researching this, and we've now published a lot of work in this. I've seen that there wasn't a lot of attention around it, and there wasn't a lot being done about it. Really motivated me and inspired me to continue looking for solutions. That's when I went out and started working with community organizations, human rights groups, to see how we could not only increase the awareness, but start moving towards solutions of where we could go to start addressing these injuries.
So tell me about what you have seen as a neurosurgery resident in terms of injuries from the border. What are we talking about?
Yeah, so as a neurological surgery resident, of course, we deal with brain and spinal cord conditions. So we analyzed the trend. When we first looked at this, we analyzed the trend from 2016 through 2021. That was our first study. To give you some more background, in 2017, the presidential administration signed an executive order directing the construction of 18 to 30-foot border walls at the southern border. In California, specifically in San Diego, the first the border walls from 18 they now range from 18 to 30 feet. By the end of 2019, they were all 18 to 30 feet. So we analyzed the trend, and we saw that from 2020 through 2021, the last 2 years compared to the 2016 period before starting in 2016, there were about just a little over 10 spinal injuries during the before period. Afterwards, we saw those injuries go up by 5-fold. More strikingly were the traumatic brain injuries. There were 0 instances of traumatic brain injuries before the border wall. Now, total in the last 2 years after the border wall was increased, there were over 100 spinal and brain injuries.
Wow.
And we do see that the trend continues to get worse since 2021, unfortunately.
And what is a typical story of one of these patients?
Yeah, of course, we can't speak about specific patients, but I would say generally, a lot of these patients, I would say, are unfortunately more and more are, the patients coming to the border are families, right? So they're young, male, female, working age men and women that are really escaping, very violent conditions, very dire economic conditions or political instability. And they make this long journey. I'm not sure if you know, but more and more of them are coming from South America,
Yeah.
Africa. So it's months long and weeks long journeys. It's not just a couple of days. It's not just, a 1 day flight, right? And then they get here and then they suffer a severe brain or spinal cord injury, which we do consider the most severe types of traumatic injuries, right?
Right.
Now they're in the hospital.
And just to be clear, that's from trying to get over the wall.
Correct. So these are people that are presenting between ports of entry, trying to come over to the United States. A lot of them, they are trying to come here and seek asylum.
Right.
But given the circumstances around everything that's going on, their options are often limited, and a lot of times they can't wait, right? So they jump over the wall and they fall on the U.S. side, and those are the people coming to our trauma center.
Now, you recently published a paper about these patients and the kind of injuries that they have compared to people with the same injuries, but not from the border. And what were the differences?
Yeah, so I found it very important to look at this because, I feel patients that suffer border wall fall injuries are suffer those injuries under unique circumstances. They have unique geographical, socioeconomic circumstances, unfortunately, political circumstances compared to the general population. And this is not just isolated to our region, right? This is happening all across the border. So what we found that, we looked at patients that fell above or at 15 feet or greater and suffered a traumatic brain injury. What we did find was that patients that suffered border wall fall traumatic brain injuries had a greater time from the time of injury triaging to the time of, or the time of reported injury to the time of hospital admission, had a near 5-fold increase. So they came in
like how many minutes are we talking about?
So we're talking about around 50 minutes versus 250 minutes. So about less than an hour to closer to over
4 hours. Yeah, over 4 hours. So if somebody falls at the wall, it's like 4 hours after the brain injury before they come into your hospital.
Correct. Yeah. Correct. That was on the reported. That was on average what the difference was. Of course, this is just looking at once they come into our hospital. So, of course, when they suffer the injuries, a lot of them are in remote regions where it's difficult to even get people out there and finding that someone's injured and bringing them in. But those are the circumstances that I wanted to highlight, that the injuries that they suffer are in much more unique circumstances. And for traumatic brain injuries, time is of the essence, right? It is important to treat them, not just surgically, but medically. Treating, traumatic brain injuries are very important, right? So we did see that when they came in, they did have higher rates of a severe form of traumatic brain injury that we call diffuse axonal injury. And they did require more operations. Unfortunately, they did have more neurological deficits at discharge, and they did have less follow-up care. Even if they were, we gave them an appropriate follow-up, but for whatever circumstances afterwards, they didn't show up for their appointment.
So you have people who are trying to come to the United States, many cases to seek asylum, but they wind up with these severe injuries and worse injuries than even run-of-the-mill, if there's such a thing. Neurological injuries, they're worse. They get less follow-up care. Why is this important for people to recognize?
Yeah, so I think there's two components to this, and the primary component is that I will say that there's certain policies that we have put in place that exposes to a vulnerable population to significant harm, right? That's the first thing that I think is important to recognize, that the infrastructure that we currently have in place does expose this vulnerable population to significant harm. Secondly, that's what's occurring right now. These people are suffering severe neurological injuries, And I wanted to emphasize that there's opportunity for us to improve that experience, right? From injury to after they're discharged, right? There's opportunity to improve, finding these patients that are injured along the border, triaging them at a more timely manner so we could treat them once they come here, and making sure that they get the appropriate follow-up care. A lot of that, I would say that another finding that we had was there was differences in insurance coverage. So less of them more of them had government coverage. And as you probably could imagine that there's less, it's very difficult to place them at a rehabilitation center with less optimal coverage, right? So that's another important point that I wanted to highlight was, after they're released, improving their insurance options and healthcare coverage afterwards is another component.
And of course, there's also prevention.
Right. So prevention is, that's the thing that's what a lot of our prior studies have been working towards, right? First, increasing awareness, making sure that, people know that the health hazards that our current border infrastructure has resulted in, and trying to move towards, alternative solutions to make it a more safe journey for a lot of these asylum seekers. As I mentioned, I speak to a lot of them, not only in our hospital, but, through my community involvement. I can tell you that the majority of them, the majority of them or everyone I've spoken to, this is all anecdotal, right? But they are, just honest, hardworking people that are escaping very dangerous conditions, and any of us would go through that same journey.
So a more humane immigration policy would mean fewer severe neurological injuries.
I would say that that's something that we should definitely look, those are the alternatives that I'm hoping to encourage our public to look into. There's definitely different solutions or different alternatives than creating a 30-foot border.
I just want to maybe end with a question about what it's like for you, given what brought you into medicine and neurosurgery, to be able to use your expertise to shine a light on this problem.
Yeah, so I do consider this a privilege, honestly. And through a lot of the work that I've been able to do and the platform that I've been given, I do feel that it's my duty to continue speaking out on this. I'm not sure if I mentioned it, but I was given the opportunity to testify in front of U.S. Congress on the dangers or on the injuries that we've seen from our current border infrastructure. And through that experience, I've found that even just with my title, I'm given a significant voice for this community. And given everything I've seen, not only growing up as a kid in an immigrant household, but seeing what I've seen at the hospital, seeing what I've seen out at the border, I do feel that it's my duty to continue, speaking up for this population that often doesn't have a voice.
Well, you have done so very effectively on this podcast. And thank you so much for all the work you do, Dr. Tenorio, and for joining me today.
Thank you, Josh. Thank you for letting me speak on this issue. I appreciate it.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.